there that if you have osteoporosis, get diagnosed early because they can help it not get worse.
Right.
How do we do that? Because I've been on anti-inflammatories and I don't see that it helps all that much.
For osteoarthritis?
I'm sorry, osteoarthritis. Yes, I'm sorry.
It's going to depend on the root cause for your osteoarthritis. And, you know, we lump so many different types of arthritis in under osteoarthritis. So, along with the anti-inflammatory, though, if there's a wear and tear component to it, I like people to get in to see a physical and occupational therapist to work on minimizing those things, okay? Because if you are in that category and you just repeatedly keep using the joints in ways that just gives them repeated small damage, they just can continue to get worse. So it's typically not just the medicine, but a comprehensive approach to that. What else?
You mentioned something about falling. It can be due to the inner ear, too.
Yes, there are so many different causes of why people can fall. So thank you for pointing that out. And that's what's so important. Unless you've got just a really good reason why you fell. Okay? But if otherwise you really can't explain that fall, or you're falling more often, or feeling less steady, get in to your provider to get that full workup to look at all the potential causes. And even with the inner ear, the vertigo, they're coming up with non-medication ways to treat that. A lot of it has to do with all those little cells, hair cells and stuff like that in your ear. So they've got some really neat techniques out for that.
And you can fall, you can look up and look down and fall because of the inner ear.
Oh, I know. I had an inner ear problem once some years ago after just a joyous boat ride. And I remember trying to, after that boat ride, yes, I wanted to take a shower. I had to sit down because I could not even close my eyes to wash my hair without going over. It's amazing.
Dr. Raleigh Jones here.
He's out at Cardinal Hill, too. We stole him over there for a while. Okay. We gave him back. We did. Any other questions? Yeah.
Aging brains.
Yes.
Now,
I have one.
You can, what I hear, and reading between the lines what you said, there are medications that can sort of delay the onset of some of these symptoms. Is it true, the New York Times article in the last 6 months, it said at the big international conference that they really aren't, with Alzheimer's, they really haven't found any real treatments at this point.
There's not a cure.
Yeah.
But the medications across the board, okay, when you look at the research studies, those people on the medicines compared to those people not, the people not declined faster.
But at some point they sort of catch up, don't they? I mean, it's good to put it off, let's face it.
It helps slow the progression.
Yeah.
And as long, the studies that I have seen
Yeah.
still show a difference
Good.
between the people on the medicines and not. And having practiced before these medicines were available, I can see such a big difference in our folks in nursing homes who have been on these medicines. And some of the biggest differences I see is they still maintain the ability to eat. So when I started practicing in geriatrics, the big thing was, Mom's got Alzheimer's. She's losing that ability to eat. She still recognizes us. We still can meet with her and feel like we're having quality of time, but I don't want to put a tube in her, feeding tube. What I've seen on these medicines, though, is that more people maintaining that ability to eat. So it helps preserve function in ways that aren't just prolonging, but adding quality. So.
Well, I don't want to dominate here, but why can't they eat? What happens with that age of Alzheimer's?
You're losing that neurologic ability that guides your ability to eat. Used to it was thought, oh, they forget to eat. Could any of us in this room forget to eat? Me neither. Okay. The theory is that it damages the hunger center of the brain, so you're not sensing that you're hungry. Okay, so you're losing that. Then you're losing the neurologic function. To actually see food, know you need it, get food, neurologic function to chew, neurologic function to swallow.
I'd just like to add Dr. Dyke's research here at UK is.
Who did I tell you needs to talk next?
And, I heard him at an earlier seminar like this. They have had it before. It's been wonderful. But they're very encouraged with some of the things that they're doing that are actually reversing the tangles in the brain and things like that that they didn't anticipate were going to happen. And as usual, it's money for research and focus and a low budget on it. But anyway, there's still encouraging things out there. And my mother passed away from Alzheimer's. And excuse me, still fresh. But the Aricept things, she participated in a study here, and it did make a difference.
Yeah, Terry and I were just talking. I was going, Terry, they've got some new guidelines on Alzheimer's. We need to get Dr. Jike out here. I had the sheer honor and pleasure of working with Dr. Jike out with Sanders Brown and staff, so he's fabulous. Yeah.
If your dad was, if there was a decline in your dad, where would be the first place that you would send him for care? And we can't tell if it's depression or is it medication he's on? What doctor would you send him to?
The decline is cognitive, physical, combination thereof.
Could be, he just wants to sit in the chair all day. Driving isn't as safe.
So get the safety things in place. Get him in to see the primary care provider, okay? Because oftentimes, if it's a medication side effect or anemia, those basic things that primary care is going to do. I know some primary care providers that just embrace geriatrics and do a fantastic job. Other primary care providers know that that's just not the area they focus on in their practice and would want to see the person referred on. So,
and that's what I want to know. Who would you?
So, when you go to that step, okay, geriatricians like me, okay, neurologist. We do have a geropsychiatrist here at UK. If it was just a pure physical functioning without the cognitive, I would think about a doctor of physical medicine and rehab also. So you've got a number of different experts around. And then at some point, you might want to combine in physical and occupational therapy, depending on what's found. Okay? If it is more depression, once we dig deeper, then going with somebody who actually does the counseling. So psychologist, LCSW, licensed clinical social worker, family therapist, things like that. It's a real comprehensive approach. Any other questions? Yeah.
What do you think about glucosamine?
Okay. I'm sorry. What was that again?
What do you think about glucosamine?
Glucosamine.
The last research I saw on glucosamine for arthritis did not show a benefit across the board, but there were subsets of folks that benefited from glucosamine. So, if people want to give that a try, I usually encourage them to give it a try. Make sure they give it an adequate trial, and I've forgotten the exact duration that you're supposed to stay on it to really see if you're going to benefit.
Well, and there's different glucosamine products, and I've heard some are more beneficial than others too.
Yeah, I've
The ones
heard.
with the sulfates or something.
Yeah, and I'm sorry, I can't quote the literature on that. Anything else? Yeah.
The dementia Alzheimer's thing, I've heard everything from there's so many different types to it's really all the same thing. If you know someone who's elderly and you can see that they're starting to falter, but they're not really wanting to go to the doctor, and you don't really know if you should push it, are there any telltale signs of that it's Alzheimer's rather than just normal dementia, and that, yes, let's get you to the doctor because medication might help, like scenario?
In general, the memory disorders, the Alzheimer's, vascular, Lewy body, very often will all look the same. Going on about how there's all different types. When we look at Alzheimer's, a lot of us think Alzheimer's is probably numerous different conditions, all looking similar. So there's like the early onset and the late onset and stuff like that. Sort of like the common cold. Yeah, all the same symptoms, kind of a different virus, doing similar types of damage. Okay? And so we are just at the tip of the iceberg of sorting that one out. The first symptoms, that's when I like to get people in. Because often it's not a dementing illness, it's low thyroid. It's a medication side effect. Sleep apnea. I have found a lot of that in people presenting with just that foggy, cobweb kind of feeling, and finding something very treatable. Okay? The other thing, too, is the sooner you start the medicine, the better. It's preventive. It helps slow progression. So a lot of the folks I take care of, they're going to say, well, we'll start something when it gets bad. And it's too late. It's not like so many of the other diseases where, well, I'll go on a payment when that back gets bad enough. But I'll, So it's a different way of thinking about conditions as you think about the prevention. But I like people to get in as soon as possible. And safety is a big issue. Okay? What else? Okay, well, thank y'all so much.
I just want to mention really quickly that this was brought to you by UK Health and Wellness and also Elder Care or Plus Life. We are going to put this PowerPoint presentation up on our website. We will also have a video of Dr. Stiles on our website as well. So if you want to watch this again, if you want to refer this out to friends and family, they're more than welcome then to click on that and get the information. But let's thank her again for coming today. Other Health Smart Conversations. Thank you.
There's a garden here.
Oh, yeah, only sacrifice a few lives and let the rest go.